Ready? Okay. All right. I think we're going to go ahead and get started if everybody's okay with that. So today we're going to talk a little bit. Everybody ready to get started? All right. Lots of socializing this morning, which is nice. This is a big group. I don't think I've seen this many people yet. So this is great. All right, so today we're going to talk a little bit about cognitive changes in Parkinson's disease, which is a question that I think everyone has when they get diagnosed. You know, what is going to happen to me? What are the changes that I might have as I move forward in the disease? So we're going to talk a little bit about that. So there are some normal things that happen with age, right? Everyone talks about, well, it's just age, right? I'm just getting old. So these are the things that I'm going to change with my memory as I'm getting old. Well, there are some things that do change. So things like delayed free recall, which is spontaneous retrieval of information from memory without a cue. So remembering when you go to the grocery store what you want to get, that becomes a little bit more difficult as you get older. You may need a list, right? Or source memory, knowing where or when you learn something. Remembering if you learned a fact because you saw it on TV. So that becomes a little bit more difficult as you get older. And then prospective memory. So remembering to do things in the future, like remembering to take your medicine before you go to bed, that might be something that becomes more difficult as you get older, and that's normal. Stays the same with age though, things that should not change unless there's something going on like a neurodegenerative disease, recognition memory. So retrieval of information when given a cue. So like if someone tells you a story and they ask you questions about it, you should be able to say yes or no based on what they've just told you. And then temporal order memory, like remembering the correct sequence of events. So remembering that you went to lunch with your friends and then you went to church. So remembering those things stays the same. And then procedural memory, remembering how to do things like using the microwave, using your remote control, learning how to ride or riding a bicycle. Those things don't change with age. Learning how to use remote controls, I have problems with now, but if you remember, if you learned it a long time ago, it's something that should stay with you. Okay, so activities that are associated with good cognitive function in older adults. So intellectually engaging activities. So puzzles and things like Sudoku and other things like that, there's been a little bit of controversy whether or not it prevents the slowdown, but it definitely engages your brain a little bit more, better than just sitting around watching TV all day long. So those things can be helpful. Using the computer, playing cards, playing board games, playing musical instruments. So things that you enjoy doing, you should continue to do. Physical activities. So this is extremely important. Physical activity is really important in delaying cognitive decline. So any type of exercise is good. What we say is if you like to do it, that's what you should do. So in Alzheimer's disease patients, memory is really the biggest problem that they have. So in the beginning of the disease is things like remembering, people's names, remembering new information, short-term memory that can be affected. And then as time goes on, it becomes difficult to remember long-term information. So the temporal lobes, you can see at the bottom, are really shrunken down. So that's something that we see. And then the brain itself is very shrunken. So the whole brain kind of shrinks with Alzheimer's disease. So what do we see in Parkinson's disease? So in the beginning of the disease, there's something called bradykhrenia, which means slowness of thought. And so patients will remark oftentimes that it takes them a moment to think of something. So someone asks you a question and it just takes you a pause before you can answer the question, or it takes you longer to perform a task because it just does, things feel like they're in slow motion. And this is normal. It's just from the dopamine being decreased in your brain. Dopamine is needed for these types of functions. So you don't have dopamine to do that. So you become a little bit slower. But that is not dementia. Then there's mild cognitive impairment, which means that there's one area of your cognition, and we'll talk about areas of cognition that is not functioning at an appropriate level. Everything else is normal. So you may need, like if your short-term memory is not good, you may need to make lists, or someone might need to remind you of the conversation, but everything else is fine. You can pay your bills, you can get dressed, make your food, things like that, but just that one area is declining. And then in dementia patients, you need help with day-to-day functions. So things like paying bills, cooking, things like that become more difficult, driving. So less severe end of the spectrum with cognitive changes are bradykhrenia, and then more severe as the disease progresses can be dementia. So what are the changes that we tend to see with Parkinson's disease? So these are 5 areas of cognition. So when we talk about cognition in the brain, we're not just talking about memory. So when we say dementia, memory can be fine. You can have other problems that lead us to give you the diagnosis of dementia. And these are the different areas of cognition or cognitive functioning. So attention and working memory, executive function, memory, visual spatial function, and language. Okay, so attention and working memory. In Parkinson's disease, you can have decreased attention and concentration. So difficulty juggling multiple things in your memory can also be difficult at the same time. So paying attention to a television show, reading a book, you kind of lose your place, or you feel like you've got to read the same thing over and over again. That can be difficult, or juggling multiple things in your memory at the same time. Executive function. This is really pronounced in Parkinson's disease patients. Patients will often have problems with executive function earlier in the disease process because executive function is really fueled with dopamine. So these areas can be really affected. So trouble with multitasking. So that's a big problem in Parkinson's patients. So, if you're driving a car, you should not be having a phone call at the same time, because that's going to be too difficult. People will have trouble with organization and planning. So, that's self-explanatory, but those types of things are more difficult in Parkinson's patients. Difficulty switching focus and tasks. So I hear this a lot from my patients, that they go into a room and they're doing something, they leave the room to do something else, and then they can't remember what they were doing in the other room. They know they were supposed to finish something, but they can't remember. So they have a bunch of unfinished tasks everywhere. So that's why we tell patients, do one thing at a time, have a plan to do one thing that day, get that one thing done. Don't plan for yourself to do multiple things in one day, because you're not going to be able to finish them. And that's just the dopamine system, right? And then decreased initiation of activity. So apathy can be a really big problem. So apathy is not specifically depression. You're not sad, you're not anxious, you just don't want to do things anymore, things that you used to like to do. And that's not necessarily a function of depression. It's just a function of the executive system not working appropriately. So you just have a lack of motivation. So memory, so cognitive changes in Parkinson's disease, you can have progression of loss of short-term memory. So that's things like remembering what you watched on TV last night, or remembering what you saw in the news, or a conversation that you had with a family member, but long-term memory doesn't change. So things like remembering where you went to elementary school, or, remembering events from your childhood or your kids' names, things like that don't really change in Parkinson's disease patients. Alzheimer's disease, that's really a fundamental problem in that, is that they tend to lose short-term and then it progresses to long-term memory as well. So that's a really big difference between Alzheimer's and Parkinson's disease dementia. So language function. I get this a lot, the tip of the tongue phenomenon, where you feel like that word is just right there, but you just can't think of it. That's really common in Parkinson's disease. And that can be early on in the disease process. That's not necessarily something that means that you have dementia or that's developing, but that's that slowness of thought problem that we're having with the dopamine loss, is that you just can't think of the right word, and that it just won't come. And then eventually it comes, but it can be kind of socially awkward when you're having a conversation and kind of sticks in the memory that you know what you want to say, but it won't come out. And then trouble finding the right words. So it's kind of a similar thing where you know what you'd like to say, but you can't say it. So a lot of patients I'll see will talk around something. So they'll describe what they're wanting to say as opposed to saying exactly what they mean, because they can't find the right word. But again, you won't lose the ability to speak. So in Alzheimer's dementia, patients do end up losing the ability to communicate, but that doesn't happen in Parkinson's disease. So visual spatial function, this is again a really big problem that we see in Parkinson's disease alone, is visual spatial abnormalities. So things like parallel parking your car, period, pulling out of the garage, you may have more difficulty because you can't navigate things in space as well. So getting lost in familiar places, that can happen more frequently as well, just because you can't navigate in your head as well where you are in space. And then misjudging distances and locations. So that's like, when you're walking straight down the hallway, but you hit your shoulder on the door frame. Those types of things can be more difficult because you just can't judge where you are in space. And that's very, very common in Parkinson's disease. So that's why driving is such a big issue. And we have to talk about driving really frequently, because even if you feel like you're pretty normal, your driving might not be as good because of this specific problem that we see in Parkinson's disease. So in Parkinson's disease, we see impairments in attention, executive, and visual spatial functions way more than we see problems with memory. And then as the disease progresses, we can have problems with behavioral changes, hallucinations, apathy, and then paranoia and delusions. So don't panic. We do have ways to treat these things. So this is not necessarily going to happen to you, but this is something that we do have to be aware of so that if it starts to happen, we can deal with it at your appointments. So fluctuations in levels of arousal, that's really a hallmark of Parkinson's disease dementia, or a disease that's related called Lewy body dementia, where some days you're totally normal, some days you're not normal at all, some hours you're normal, and then later on in the day you're not doing as well. And also it can be as severe as being awake and asleep. So you're totally awake, and then the afternoon you're totally asleep, and your family members really have a hard time keeping you awake. So that's a really common thing in Parkinson's disease dementia and dementia with Lewy bodies. Hallucinations are really more common in Parkinson's disease dementia and Lewy body dementia. Depression, and then sleep disturbances. So talking in your sleep, acting out your dreams, that's more common in Parkinson's disease patients, and really a hallmark of Parkinson's disorders, as opposed to other types of diseases, especially Alzheimer's disease. So what are the risk factors? So age, dementia is just more common as you get older. So the older you get, the higher you are at risk. Severity of motor symptoms. So if your motor symptoms are really severe, that means that you're a little bit higher risk because the disease is further progressed. Longer disease duration. So the longer you have the disease, the more likely you are to have dementia. And then cognitive impairment at the beginning of Parkinson's disease. So if that's happening, then you may have Lewy body dementia, or you're more likely to progress to have dementia as the years go on a little bit sooner. And then akinetic rigid type, which is a type of Parkinson's where you don't have tremor, where you're much more stiff in the beginning. Those patients, for some reason, have more risk of developing dementia as the time goes on. Any questions so far? Yes?
Is that a separate?
Yes. That's a separate disease. Yeah, I'm sorry I didn't make that clear. So Lewy body dementia is a disease where you have Parkinson's symptoms and dementia at the same time. So Parkinson's disease dementia patients, they'll have 5-10 plus years until they develop any cognitive decline, significant cognitive decline. Patients with Lewy body dementia, they have dementia as their predominant feature, and then they will have a little bit of Parkinsonism on their exam. So those of you who are here today, most of you are on, probably all of you have Parkinson's disease and not dementia with Lewy bodies.
Is there any minerals or vitamins that can slow the process?
No. The best thing is exercise. So exercise. That's the best thing that you can do for yourself. We'll talk a little bit about that. And then hallucinations. If you have hallucinations earlier in the disease, you're at a greater risk factor for getting dementia as the disease progresses. Any other questions? I think I'm just standing too close to this. Okay, so hallucinations. The definition is a false or distorted sensory experience that appears real. It's generated by the mind rather by external stimuli, and may be seen, heard, felt, or even smelled or tasted. Now, by far and away, the most common hallucination type in Parkinson's disease and Lewy body dementia is visual hallucinations, and they're very, very well formed. That is really the most common kind, but you can experience any type of hallucination in Parkinson's disease. So it's really common. 6 to 60% of patients with Parkinson's disease develop hallucinations, especially later on in the disease process. So types of hallucinations, so illusions, mistaking a real object for something else. So that's like if there's a coat rack you're seeing out of the corner of your eye, you think it's a person, then you look at it and you realize, oh, that's a coat rack. So that's an illusion. Sensory illusions, feeling like someone's walking behind you, someone is in the house when they're not. So that's a sensory illusion, sensing a presence. And then visual hallucinations are by far and away the most common, like I said. So simple ones can be flashes of light, geometric shapes, and then complex are well-formed things like animals, people, objects. People and animals are definitely the most common. And then most of the time you can recognize them as being false. As the disease progresses, it may be more difficult for you to recognize whether that's real or false. But typically in the beginning, you're able to actually recognize that's not real. And then delusions are paranoia or false beliefs. So believing someone's out to get you, believing there's people at your house watching you, things like that. So hallucinations by far and away, most of the time are not bothersome to people. So you'll see a cat or you'll see a family member, but they don't really bother you. Occasionally we'll have patients who see bugs and that can be disturbing, but most of the time it's like, oh, I see my mother in the corner, or I thought my son was in the room last night, but it's not anything that's really like, there's a monster, there's zombies, like that horrible pimavanserin commercial where that poor man is like sitting, the Nuplazid commercial. Have you seen that one where the guy's like in his house, like with the shades closed because he's afraid of what's going on? That is not the typical Parkinson's hallucination. It's usually like there's a cat or there's a rabbit or why is there, a little kid in the house? Like those are the types of things that we hear about, but not specifically scary things. So sudden changes, we need to talk about this. Sudden changes in Parkinson's disease are not due to the Parkinson's disease. So whenever you have a real sudden change, like you've never experienced hallucinations or delusions before, and all of a sudden you're thinking that your wife is stealing money from you, that is not Parkinson's disease, right? We need to exclude other causes such as infections, things like that. Even having more sleeping or being extremely depressed, we need to exclude other causes. So urinary tract infections, that's why whenever you call the office and tell us that you're having issues, we want you to go get a urinary analysis to make sure you're not having a urinary tract infection, because this is extremely common in Parkinson's patients because of the autonomic dysfunction that you have. So your bladder's not working as well. You're not completely emptying it every time you go to the bathroom. And then there's a little bit of urine in there that can cause you to have a increased risk for infections. Really, really common. So that's why we always ask you to get this checked. Other things like pneumonia, you may not know that this is happening to you, and then other types of infections. So now it's like flu, COVID, God only knows what else is going on out there, but those types of things. And then something else to think about is severe constipation. I have had patients who've had really bad impaction, and that causes their Parkinson's symptoms to just tank. And one of the reasons the gut's not moving, you're not able to absorb your medications as well. And so constipation is really a symptom that can cause this. So if you're really having difficulties with this, definitely talk to us, talk to your primary care doctor about trying to get some relief from that, because this can cause, your Parkinson's symptoms to worsen quite a bit. And then any recent medication changes. So there are a lot of psychiatric medications that can cause problems with worsening Parkinson's disease. Not everyone is aware of these side effects. So you may get a well-meaning physician or practitioner give you a prescription for something like Abilify, and then your Parkinson's gets crazy out of control. And this can be something that we see pretty frequently. Medication refills with different appearance than usual. So we have had, or I have seen patients myself who have gotten controlled release formulations instead of immediate release formulations, or the opposite, and they're taking way more than they should be because of a pharmaceutical error. So if you see your pills are not looking the same and you're acting a little different, then definitely give us a call. We can check and make sure that that's not something that's, causing your problems. Cough and cold medication, things like NyQuil, that can really make you a little bit more confused. Sleeping pills, even things like Tylenol PM or Unisom, anything that's sedating like that, those things have what we call an anticholinergic effect. And acetylcholine is really important for memory. And so when you have an anticholinergic medication, it blocks those things. And so you can become more confused. So there's a lot of medications that have anticholinergic effects. I'm always looking for them. Michelle will always look for them on your medication list to make sure that these are not things that you're being prescribed on accident that could potentially cause worsening memory.
Would you write that word down to?
The anticholinergic. Yes. So anticholine, CHOLINERGIC, anticholinergic. So it's CH.
Yeah.
Okay.
Mhm.
Yeah, so those things are not good to take. Benadryl is one thing that I see a lot where patients think it's not a big deal. I'll take some Benadryl to go to sleep. You're doing that every night, and then you start to become more confused, or you feel like your memory is just tanking, and that's because of the Benadryl. And then pain medications too. So when you have a surgical procedure like knee replacement or anything, you're going to get prescriptions for narcotics most likely. I don't want you to be in pain. We don't want you to be in pain, but try to wean yourself off to non-steroidal anti-inflammatories like ibuprofen, Tylenol, things like that as quickly as you can, because narcotics can really cause problems with hallucinations and delirium, especially in combination with Parkinson's medication. So you really want to get off of that as fast as you can. Comfortably, we don't want you to be in severe pain, but as soon as you can transition off of those, that's the best thing for you. And then, like I said, review your medications with your doctor. If there's some concern about a medication that you've been prescribed that you're not feeling quite yourself after you've been taking it, definitely let us know. This can be anything from a, over the counter to, a blood pressure medication. So please let us know.
Did you include Tylenol into that? Not PM, but just.
No,
Tylenol?
regular Tylenol is perfectly fine to take. Yeah, Tylenol PM has Benadryl as the component that makes you sleep. So that's why we don't like to use it. I think you in the back. That's okay. Yeah, Zyrtec is fine. Those are they're second generation antihistamines. Those are good. Okay. Melatonin is good. Yeah, we use melatonin a lot. Patients with Parkinson's disease have decreased levels of melatonin, so it actually can help you more than the general population falling asleep. CBD is not, I have not seen it cause problems with delirium, delusions, anything like that. Now, we're not in a state where THC is legal to get at this point, but if it has THC, like if a friend brings it over from a different state and it has THC in that, you may want to be a little careful because THC definitely. CBD, I've not seen any problems with patients taking CBD, just plain CBD. Yeah. Okay. All right, so gradual changes. So what do we do when we start to notice these things happening? So we try to simplify our medication regimen as much as we possibly can to help with balance, but also think about cognition. So if you're using a walker or you're using a wheelchair, God forbid, you may not need as much medication because you're not up and about, right? As much as someone would be if they're still working. So we may simplify your medication regimen to allow a little bit more off time, but your memory's clear. So those are things that we tend to do as the disease progresses. Levodopa is the least likely to cause cognitive changes, hallucinations, and delusions. So if you're on things like pramipexole, ropinirole, entacapone, rasagiline, all these different types of medications, we will simplify that as much as we possibly can to get you just on levodopa and the short acting form, not the long acting form, so that we can get you clear, we get your meditation clear. And then maintain a structured, familiar environment. So you may notice in your family members or in yourself that if you take a vacation or you go visit loved ones, that being in an unfamiliar environment, especially at night, you wake up and you get confused. You don't know where you are. And that's when we tend to have falls because you're like, I don't know where the bathroom is. I think I'm at home. And then you fall down the stairs. Something awful like that happens. And I've had patients that has happened to. So, definitely that's something to be wary of, especially later in the disease, that if you are in an unfamiliar area or if you move from your house to an apartment or something like that, it might take you a minute to get accustomed to that. It's not to say that you shouldn't do those things, but just to be aware and to have your family members aware that there may be a little bit of, especially at night, needing some help to get to the bathroom. And then an individualized daily schedule can be really helpful. So doing similar things every day, structured routine can be helpful in not having that, what's going on, what am I doing? You know exactly what you're going to be doing every day. So cognitive rehabilitation therapy, where it's available, can be helpful. It's not available everywhere. So I don't think we have anyone here who does it, but it can be helpful in some cases. So Medications as needed. So we do use medications to treat cognition. And these medications can be really helpful. So the medications like donepezil and rasagiline, these things, or rivastigmine, excuse me, these things can be actually more helpful in Parkinson's dementia than in Alzheimer's dementia, because the level, these medications, what they do, they boost a chemical in the brain called acetylcholine, which we talked about is really important for memory. And in Parkinson's patients, that level is much lower than an Alzheimer's patient. So when we boost the levels, you can have a significant change. So we use that a lot, and I feel like that's really helpful.
Do you need a printout of this so people can-
I think it'll be available online. Sandra, are these available online?
They are, we have a YouTube page. It usually takes up to 2 weeks for them to get loaded.
Okay. Yeah.
I can share that link with them.
Yeah. Okay, great. And like I said, this is information that your doctors know. So like I said, donepezil and rivastigmine, these are really helpful. They do have some side effects. Donepezil can cause some problems with stomach upset, but Exelon comes in a patch form, and I think donepezil is coming out with a patch form, so that'll be helpful to prevent some of those side effects. And then memantine or Namenda is an NMDA antagonist, and this is also something that we use in combination with donepezil or rivastigmine. So to treat psychosis or hallucinations and delusions that can happen, what we do, we reduce unnecessary medication. So like we talked about before, we really try to pare off your medications, pare down your medications to only levodopa if we can, because that should clear up your mentation quite a bit. So if you're not needing it to be quite as mobile, we tend to decrease the medications a little bit to clear up the mentation over time. We can use antipsychotics as needed. So these are things like quetiapine at very low doses, clozaril, which is an antipsychotic that we really only reserve for very severe cases, which is rare, but we can use it. It requires a blood test, so we don't use it first line, but we can use it. It works really well. And then Nuplazid or pimavanserin, which has that horrible commercial, but it does tend to work. So we can use that as well. So driving. So driving is something that we need to talk about at a lot of your appointments. And if your family members are concerned about your driving, then you definitely need to reconsider driving. So driving depends on vision, motor function, attention, and cognition, right? So we talked about how your attention can be impaired even in the beginning of the disease process, being able to concentrate. So don't talk on the phone, don't have a conversation in the car, don't listen to talk radio where you're going to be really emotionally aggravated and then you're driving your car. So drivers with Parkinson's disease do tend to make more motor safety errors. So obviously, if you're going to go on a long road trip, you don't know where you're going, you may not want to be the one to drive. Even if you're cognitively normal, you may want to have your family member take the wheel. Challenging, especially in Parkinson's, is driving with low visibility, dangerous intersections and curves, unfamiliar roads and new routes, and then searching for landmarks and distractions. So these things can be really difficult. So driving to the same place every day, and not on the freeway, that should be fine. But as time goes on, you may have more difficulty. And then diagnosis of Parkinson's disease alone does not predict driving fitness. So just because you have Parkinson's disease does not mean that you cannot drive. It's something that we have to reevaluate over time. So people with PD, yourself and your neurologist have really bad insight into whether or not you can drive. So you tell them, I've never had a ticket, I've never had an accident, that could just be luck. So the best person to know is actually your family members, right? So who's in the car with you? If they're saying you're scary, like you're going to get in a car accident, then that's probably the time to let yourself, stop driving. So that's there's actually been studies that have used caregiver concerns as a predictive measure to predict when patients with Parkinson's should stop driving. It's not me, it's not you, it's the person who's in the car with you. If they're worried, then that's a big concern, okay? Recent crashes, if you crashed your car, probably shouldn't drive anymore, or near misses. Getting lost in familiar places, that's a big red flag. If you're getting lost going to the grocery store that you've always gone to, then that's a big red flag that you shouldn't drive any longer. difficulty managing intersections, so knowing when to go and, when you're at a stop sign, and difficulty with nighttime driving. So all of those things suggest impairment. But like I said, if your wife or your husband or your daughter or your son is in the car with you and they're saying, this is really unsafe, you really shouldn't drive, you should probably listen to them. All right, but giving up driving is associated with depression, decreased mobility, decreased activity levels, social isolation. So it can be really hard to give up driving. So you can use compensation strategies to decrease risk, like don't drive in bad weather, only drive at times when there's light traffic, only go on familiar routes, and then no distractions. So no radio, no phone calls, just driving. And that can be sometimes helpful to keep you driving for a little bit longer. Okay. And then, now there's Uber and Lyft and other things that there weren't available a while ago. They can be a little bit pricey, but there are things that you can do if you really need to get somewhere. So you're not stuck at home all the time. So we can also do driving evaluations. So there are people that will do a driving evaluation. So occupational therapists do this. So it is out of pocket, unfortunately, but what they do is they'll do a screening evaluation to look at your cognition. Then they will do a computerized assessment. So like a video game where you drive, and then they'll take you on the car, but you got to pass the first two before they'll let you get in the car. If you don't pass the first two, they're obviously not going to get in the car with you. So that can be something that we can do. So if the family is a little concerned or you're concerned and you're not really sure if you should be driving, this is obviously a good option to be able to tell you whether or not you should be driving. Okay, so Parkinson's disease takes a team, right? This is not a disease where you just go see your primary doctor once a year and you're fine, you're good to go. This is a disease that takes a lot of people around you to help, especially as the disease progresses. So it's your care partner, your family and friends, your neurologist, the nurses in the office, sometimes a social worker, your primary care doctor can be really helpful. Then we can use things like physical therapists, occupational therapists, speech and language pathologists, psychiatrists if we need one, psychologists for talk therapy, dietitians sometimes can be helpful if you're losing weight or you're very constipated, and then spiritual support groups can be really helpful. So like I said, social isolation is the worst thing that you can do for yourself. So that's why COVID was really bad for Parkinson's patients, because everyone was isolated. Nobody was going anywhere. It was really terrible for our patient population. So now that that's, calmed down a little bit, it's really important to maintain your social structures and your friendship circles. All right, so all online information is not created equal. So you don't want to just go on Google and type in Parkinson's disease or type in dementia, because you're going to get a bunch of stuff about, take this pill and you'll be cured. And that's not true. So the best places to look are these three websites. And there's the American Parkinson's Disease Association as well, but these are the best ones to look for. So Michael J. Fox Foundation, excuse me. They have a lot of information about ongoing clinical trials, what's upcoming. They do trials themselves. There are trials that you can participate in online. You don't even have to go anywhere. Lots of surveys that you can take. So you can be helpful in, teaching other people or having us learn a little bit more about Parkinson's disease. The Alzheimer's Association is really helpful, not just for Alzheimer's disease, but for if your family members suffering from dementia, what are some things that you can do to help them in the home? What are some things that you can do, to help your family member feel more comfortable? And then just, what can you do yourself so that you don't get burned out taking care of your family members? And then the Parkinson's Foundation is great. They have a ton of patient-facing materials, things that are easy to read, understand, and then you can do, they have webinars that happen all the time. It's a really great foundation. So in summary, attention, short-term memory, executive and visual spatial functions can change over time. Hallucinations and dementia can occur as Parkinson's disease progresses. New or sudden changes, like we talked about, anything new or sudden should prompt an evaluation by your primary care doctor or look for any sudden medication changes. And then gradual changes can be addressed with simplification of your medications, adding medications for cognition, and then non-pharmacologic therapies and applications. So you are not alone, like we talked about. Build your team. Don't be afraid to talk to your primary doctor or your neurologist about these issues that you're facing. And then please drive safely and use available resources. Okay. So that's it for the talk. Any other questions? Yes.
Just a quickie. All of a sudden I have that excessive saliva.
Uh-huh.
I see someone like you and medical doctor.
There are medications that are used for saliva, but they can cause cognitive problems. So I'd probably talk to your neurologist about that. So yeah. Yeah. So talk to me about that. Okay. Uh-huh.
Any particular exercise that would be
Yeah.
effective?
So anything that you will do that you like to do is good. There have been a bunch of studies looking at different types of exercises and cognitive decline in Parkinson's disease and just motor decline in general. So increasing your mobility. So things like aerobic activity is really the best. What we think there's the best evidence to support that. So what that means is you're getting your heart rate up to 80% of your target maximal heart rate for your age. And that might be hard for a lot of people because a lot of people are on medications that keep their heart rate low. So what I like to say is, if you are able to carry on a conversation while you're exercising, you're not working hard enough. So you want to be able to, you don't want to be able to like have a leisurely stroll with your friend. Like that's just not going to be enough. You got to really work a little bit harder. And if walking is not good because you're afraid you're going to fall, get in a pool, do some bicycling. Recumbent bike is really easy to get on and off of in Parkinson's disease patients, but other things can be really helpful. But like I said, what you'll do is more important. So stretching exercises, Tai Chi is really good. Yoga is really good for balance, but not necessarily good for slowing down the disease process. And then weight training, there's been some evidence to support that as well. Weight training is good because you lose muscle mass as you get older. You tend to lose weight with Parkinson's disease. So doing weight training can be really helpful too. But aerobic exercise by far and away is the most important. Anybody else have any questions? No?
We find that our brother has a lot of sleep disturbance,
Mhm.
and he's also losing weight.
Okay. So weight loss is difficult with Parkinson's disease. You really have to make yourself eat. So you'll lose weight without meaning to. You want to talk to your primary doctor too to make sure there's no underlying medical reasons why there's weight loss. But you do want to, obviously, if they rule out other things that are causing weight loss, then it's really just going to be increasing calories, which can be tough, because you lose your sense of taste and smell. So I always tell patients my first prescription is bowl of ice cream at night. If you're losing weight, try a bowl of ice cream. Most people like ice cream. So that's the first thing that you can do. And then things like drinking Ensure or Boost with your meals. People tend to add those in between meals, but then you get full and you don't want to eat your next meal. So replacing the Boost or the Ensure with your instead of drinking like a glass of water or tea, drink your Boost with your meal. And that way you don't fill up in between meals with the Boost or the Ensure. And then what was your other question? Sleep disturbance. Mm-hmm. So there are medications that can decrease that can decrease sleep disturbances, like talking in your sleep, acting out your dreams. But the first thing that you could try over the counter is just melatonin.
The recommended amount for how much weight?
So no, it's not really weight based. You can start with like 5 milligrams and you can go up to 15 milligrams if you need to.
That change the REM sleep disorder.
It can help it. Yeah, it can decrease it. If it doesn't, then there are other things that we can do. If you're snoring too, then we need to look for sleep apnea. A lot of times we tend to underdiagnose that. We just say you've got REM sleep behavior disorder. Here's some melatonin, and that's not the cause. So we definitely also need to look for sleep apnea, because that can cause acting out your dreams too. That's a quick fix. Mm-hmm.
I was just going to share that one of the talks we went to a few months ago was about
sleeping with Parkinson's, and the melatonin that was recommended, might have been our pharmacist. It might have been the pharmacist, it was REM fresh.
Oh, okay.
They said not all melatonins are made the same.
Yeah.
And
Mhm.
so they really recommended like REM, REM fresh.
Okay.
Just wanted to share that in case some of you weren't here for that talk.
Yeah.
That's something you know, it is.
Yeah. So like I said, melatonin, it's a little tricky. You can't take it if you're having trouble sleeping. Like, it's not like an as needed thing. You take it every night and you take it about 90 minutes before you want to go to sleep, because it works with your own body's sleep cycle to put you to sleep. So it's not like, Ambien where you're like, I can't fall asleep. I take an Ambien, I fall asleep. It doesn't really work like that. So you got to plan ahead and take it 90 minutes before you go to bed.
Is there any science behind people that have the REM sleep disorder? That it actually affects that person's quality of sleep?
Yes.
What can you speak about that a little bit?
The more violent you are in your sleep, you actually have more frequent awakenings. So you can wake up more frequently and then you don't feel as refreshed in the morning. So
Which is going to affect cognition, of course.
it can, but it's mostly just fatigue. Yeah. Yeah. If you have sleep apnea, though, that definitely can cause problems with cognition. And if you're untreated or undiagnosed, and you're not using a CPAP, then that will definitely make your cognition worse.
Sure.
Yeah.
Sure. Not getting oxygen.
Yeah. Mhm. Yeah. Anyone else?
Thank you.
Yeah, of course.